Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with our podcast editor and my co-host, Josh Berezin. Hey, Josh.
Hey, Lisa.
Today, we're going to talk about 3 articles from the journal that have been recently published online. We'll take an inside look at person-oriented recovery of individuals with SMI. This is a meta-analysis by Elizabeth Thomas. Next, we're going to be looking at the management of common medical conditions by office-based psychiatrists, an article by Ramin Mojtabai and Mark Olfson. And then finally, in a mouthful, we're going to be talking about behavioral health coverage under the Affordable Care Act. What can we learn from marketplace products? And this is a very interesting and relevant study by Maureen Stewart and colleagues.
First up, we have Elizabeth Thomas and colleagues on person-oriented recovery of individuals with serious mental illness, a review and meta-analysis of longitudinal findings. So for this paper, I think it's actually helpful for us to start out with defining some of these terms, because recovery, person-oriented, these kind of get thrown about a bit, and maybe we should just focus in on what those mean before we dive into what the study is doing.
Yeah, I think that's a good idea. I've done a lot of talks over these last few years about recovery, and half the time I see a lot of psychiatrists in the audience rolling their eyes as if it's just the term du jour, and that's something we want to challenge, and precision of language and really explaining it is a very important part of that.
So recovery is a huge topic in general, but for our purposes here, what do you think is important to know about the concept?
Well, so in this paper, they're contrasting 2 definitions of recovery. The first definition is functional recovery, and that's a definition that we in medicine are very familiar with. It focuses on kind of how the person is able to function. For example, how well they manage their daily lives, and engage in activities related to independent living, social relationships, and occupational functioning. And we measure it in a way that, we try to do it objectively.
So, like, is somebody employed?
Exactly.
Is a classic kind of functional recovery outcome, right?
Yeah. And, if you were to make the claim that an intervention improved functional recovery, that's the kind of evidence you'd give. People weren't employed at the beginning of the intervention, and they were employed at the end of the intervention.
And that's not nothing. That's a big deal. That's something that
it's very
intervention
important.
Right.
Absolutely. Yeah.
But this is talking about something that's a little bit different.
Right. It is different. And as the authors point out in the paper, the consumer survivor movement called attention to person-oriented indicators of recovery. And this really is not symptoms and not functioning, but really the extent to which individuals feel empowered, hopeful, and optimistic, and really feel that they can live a self-fulfilled life that has meaning.
These are internal experiences.
Yeah. And we all look to the SAMHSA definition in 2011, which defines recovery as, quote, a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And this recovery has 4 dimensions: health, home, purpose, and community. And one of the things about this paper is that it has built upon the success and progress in measuring this internal sense of recovery. And this is where constructs such as empowerment and hope and self-efficacy.
So we've started measuring these concepts, and we've also started to build interventions around these, fostering these things.
Exactly.
So this paper is trying to characterize some of the previous work that's gone into looking into those things, and then also to look a little bit more closely at whether recovery-oriented interventions are actually improving personal recovery-oriented outcomes.
Exactly. So, we don't know that much about the longitudinal course of this person-centered recovery, nor do we know that much. Again, we have some individual studies, but putting together the literature on how interventions affect this kind of recovery?
Right. So they do a literature review that includes studies that measure hope, empowerment, or other person-oriented recovery constructs, both before and after some recovery-oriented intervention. And if that study had a randomized control trial, they included it in a meta-analysis.
Exactly. Okay, so Josh, you want to tell us about the review?
Sure, let's start there. So they identified 23 studies that one interesting thing was that most of them, I think 81% of them, were recruited from outpatient settings. And then in terms of the interventions, I think it's helpful just to get a sense of the time course of the studies that we're talking about. So 9 of them involved weekly meetings for about 2 to 4 months. 7 of the studies had either daily or weekly meetings for around 6 months to a year and a half. And then 1 study met bi-weekly for 6 months.
So these weren't interventions that lasted years. They were relatively brief.
That's right. That's right. And so of these 23 studies, 10 of them were randomized control trials, but only 7 of them could be included in the meta-analysis. So this is about 1,700 participants. And just to cut to the chase, they found that the interventions increased measures of person-oriented recovery with a mean effect size of 0.24.
Which is a small effect, but it is an effect nonetheless.
Yeah, and then they also wanted to see if there are any factors that change the strength of the direction of the effect. So this is a moderator analysis. And they abstracted a bunch of variables from the study, including characteristics of the participants, characteristics of the interventions, and what sorts of comparison groups they used. And really, what they found is that those things didn't actually change the size of the effect of the intervention.
They did mention that there was one study which included both peers and professionals as deliverers of the service, and that combination produced a bigger difference or a bigger effect than when it was just peers or professionals alone. But it was only one study, and it's very hard to draw conclusions about that. Clearly, more research is going to be needed.
So what do you think the other take-homes are for the study?
The key take-homes for this study are that we now have an emerging, solidifying evidence base that this notion of person-centered recovery, which started out as this amorphous, mushy thing that at least a lot of professionals didn't believe.
The eye rolling.
Yeah, the eye rolling. Now we have evidence that something which consumers have told us is important to them, we can measure it, and that we can now see that certain interventions actually promote it. And I think the authors do a nice job describing it. Services are recovery-oriented if they strive to support community integration, operate within organizations that adopt and support a recovery vision, focus on and adapt to consumers' personal goals, needs, and strengths, and emphasize partnership in the working relationship. And I think you can see that that's a fairly broad definition. You know, we're not necessarily zeroing in yet on what exactly these interventions need, but there's a spirit in those recovery-oriented interventions.
Yeah, and specifically, in their discussion, they talk about psychoeducation, self-management skills, and fostering self-determination as real keys in these particular things that happen in these interventions.
And then finally, this is not the definitive study or the definitive meta-analysis. The meta-analysis and review have limitations, one of which is that there's really, they include all different kinds of recovery measures. So there's not a single measure that ties these studies together. So there's a lot of room for error here, but there's, I think, a lot of promise and hope in this research.
Let's end feeling hopeful, empowered, and optimistic. Next up, we have Ramin Mojtaba and Mark Olfson on management of common medical conditions by office-based psychiatrists. I think we all kind of have a sense that psychiatrists are not managing medical conditions in their practices, even those medical conditions that are really disproportionately affecting our patients. And this study is really putting some numbers to that hunch, which I think is crucial as we continue to move forward in these broader trends towards integrative and collaborative care models.
Exactly. I mean, someone might say, wow, this study isn't really news, but I think it is news to the extent that we can start to have a more granular appreciation of the work we have yet to do.
So they use a data set from the National Ambulatory Medical Care Survey. This is a survey that's nationally representative sample of physicians across the country where they ask providers to provide a week worth of charts for a detailed review. So for this study, they're looking at about 236,000 visits to around 11,700 physicians. Mm-hmm. And they're particularly interested in 4 medical comorbidities that are particularly common among people with a mental illness. So, people can probably guess what they are: diabetes, obesity, hypertension, hyperlipidemia.
Yeah, so they chose medical conditions that they anticipated would affect individuals with mental illness, to the greatest extent compared to, say, less common illnesses.
And that there's been an argument for increasing psychiatry, that being included in psychiatrists' scope of practice.
Exactly.
So they want to see how often physicians are recording these conditions, prescribing medications, monitoring them through labs or weight and blood pressure measurement, mm-hmm. and providing counseling on them.
Right. So there are 4 main categories of activities that the physicians were looking to see if physicians were doing. Again, just worth repeating: recording the conditions, prescribing medications, monitoring the conditions through labs, and also providing counseling.
Right. And the basic point here is to see how psychiatrists' practices differ from primary care physicians and from other medical specialties.
Mm-hmm. And I do want to point out there's something like 8 pages of tables in this study. So if you want to really dig in to all these different kind of physicians and what they're doing, it's all in the paper.
Yes, good luck. So what do you think is the big kind of headline?
Okay. Well, so here's kind of the most, I think, powerful summary data. So they looked at what percentage of physicians were doing any of those activities, of those 4, for their patients, and compared, again, internists to psychiatrists to other specialties. So the target general medical management activities were provided to 37% of visits to psychiatrists, compared with 98% of visits to general medical physicians, which is not surprising. But then what about other specialists, non-psychiatric specialists? And at least one of those activities was included in 78.4% of visits to other physicians.
Yeah, and just to kind of drill down into some of those tables, because they slice the data in a bunch of different ways, but just to give people a sense of some of the numbers. So psychiatrists prescribe medications for one of those 4 conditions, again, hypertension, obesity, diabetes, hyperlipidemia, in 8.5% of visits compared to 39% of visits to an internist's. Same sort of story for ordering blood sugar or lipid labs. Psychiatrists do that on 1.4% of visits compared to 27% of internist visits. Again, same idea for blood pressure or weight measuring. Psychiatrists do this on about 16% of visits compared to about 96% of visits to internists.
Well, and I think that you could argue that the proper comparison is not necessarily to internists. And a better comparison would be to compare psychiatrists to other specialists.
Right. So on one of their tables, they have this expanded chart where they list out 13 medical specialties. And one way of kind of summarizing the results is to say that psychiatrists treat these chronic conditions much more like orthopedists or dermatologists than they do like internists or general family docs.
Yeah. And given the fact that there has been this discussion and consideration of the importance potentially of psychiatrists who may be functioning in some sense as a primary care physician, really taking on more of these primary care types of activities, it's very clear that we're not even close.
No, we're definitely not even close. One interesting thing that they also drill down on is whether or not the diagnosis matters. I mean, we can't see through this to see if we're talking about physician practices and clinics where they're seeing mostly SMI populations, or if we're talking about...
Or have an assistant or a nurse or some kind of tech who can provide support for doing these activities.
Right, or if this is a solo practitioner who might be seeing something more on the anxiety depression spectrum rather than the SMI spectrum. So, but there are some hints in here about that. For example, people with schizophrenia had 1.67 times the odds of having one of those 4 conditions recorded in the chart than people there for other reasons. So it suggests that perhaps people who have kind of more high-risk conditions are getting more monitoring.
And I think there was also an analysis that compared individuals who had public insurance, who again perhaps might have more serious mental illness, to people with private insurance. And here again, the finding was that...
Right, they have higher odds of recording, prescribing, and monitoring, although those fell away in the multivariate model.
Right.
So what about counseling? You'd think that as mental health professionals in the counseling category, we might be doing a little bit better.
And we are doing better. So if you look at whether the visits had any counseling or education of any type, psychiatry visits have that in 12.7%. Still we lag behind general and family medicine and internal medicine, which have 19.8% and 25.2% respectively, but the range is much narrower, and in fact we do better than a number of other of the subspecialties. A final point that I think is important in understanding these data has to do with, again, predictors of when the psychiatrist visit or the psychiatrist is doing any of these 4 activities. And it turns out that if you're doing one, it's a predictor of doing more than one. And so it suggests to me that it's kind of like the philosophy or the structure or how the psychiatrist sets up their visit, that they're either doing it or doing a fair amount of it, if not all of it, or none of it.
Or the resources that are available within the clinic.
Yeah, maybe.
Or the setting.
Exactly, so that if the context supports the real delivery of medical care, the psychiatrist will be able to do, at least one, if not more than one, of each of these categories.
Yeah, so this study gives us sort of a sense of where we are right now, and also raises a lot of interesting questions about the settings that we're working in, and the how often should we be doing these things. What
is there enough time to do it, and is there enough support?
Yeah. Last up, we have Maureen Stewart and colleagues on behavioral health coverage under the Affordable Care Act. What can we learn from marketplace products? So I'm glad that we're talking about the ACA. It's been so much news about healthcare recently, and I have a feeling we're not at the end of it. So it's good to have
definitely not.
Yeah, it's good to have some clear-headed analysis to give us some background.
Yeah, and I think that as the authors of this paper point out, the data and analyses provided here may provide a good baseline against which we can measure any changes that will be coming down the pike from some of the new legislation that we're seeing. So this paper is important not just for what it tells us about what has happened, but it is important because it may be useful to understand what will happen.
Right, but what has happened has been a really profound change in the delivery of behavioral health care in the country. I mean, with the ACA and also the previous Mental Health Parity and Addiction Equity Act, the end result of that is that 62.5 million people have expanded behavioral health access.
Yeah, and that it's probably still not enough. We still, you read the newspaper and we still need to do more, but it is, these 2 pieces of legislation have had a huge impact.
Right, and presumably this is a positive impact for the people who are receiving the services. For the insurance companies, it provides a couple of challenges. So as they point out, this population of consumers the insurance companies are often spending more money on them than they're taking in from premiums.
Yeah, as the authors point out, individuals with behavioral health conditions are among the least desirable to insure, partly because spending on their care predictably exceeds premiums.
Right. And so the question is, what this paper is really asking is, are the insurance companies doing anything in the way they structure their benefits or in the services they're covering that's going to discourage this population from entering their insurance pool?
Exactly. So that's what we call adverse selection.
Right. And the way they're figuring this out is through a survey of senior health plan executives. Mm-hmm. And basically they're asking them about a bunch of different features of the plan they're offering on the ACA marketplace, and then a similar plan that they're offering off the ACA marketplace. So that would generally be like an employer-sponsored health plan.
Yeah. So they're comparing marketplace products, which are offered or have been offered through the Affordable Care Act, to non-marketplace products, which are offered in sort of the usual employer market.
Right. And so they're asking them about a bunch of different characteristics. Mm-hmm. So one of them is the type of product. Is it an HMO? Is it a PPO? They ask them how they contract out for behavioral health services, whether or not it's a national plan, if it's a profit or a nonprofit, and then also the marketplace type, right? So some ACA markets are administered by states. Some of them are administered federally. Some are administered in a combination. So getting all this information kind of just about the environment. And then they're also asking specific questions about the plan. What's actually covered? What are the prior authorization requirements? What about continuing review? And then really importantly, how is the network designed?
So what do they mean by network design? Network design essentially includes two types of restrictions on the network or the availability of providers. One is a narrow network, and when the network is narrowed, it just basically has providers you can use and you can't use.
Right.
The second type of restriction is the use of tiered networks,
which is a little more complicated.
Yeah, and the use of tiered networks permits a greater array of providers. But when you use a non-preferred provider, you have to pay more than if you use a preferred provider. And so, again, just getting back to what we're trying to do here, what the investigators are trying to do is they're going to be comparing the marketplace products from ACA on network design to the non-marketplace products on network design.
Yeah, on network design and all these other factors as well. But the interesting thing here is that they're not actually different on most of the things that they measured. So they cover similar things. The prior auth requirements and continuing review are similar. There's a little bit, a small but statistically significant difference in cost sharing, but probably not even really worth mentioning. But the way that they designed their networks did differ.
Yeah, so that's why we spent a little more time on network design, because it turns out that network design is important. And the marketplace products were more likely to have a narrow network for both general medical providers and for behavioral health providers than the non-marketplace products. So specifically, 67% of the marketplace products had a narrow network for general medical compared to only 46% of the non-marketplace products. And so that's a difference. But then there's actually another comparison that's kind of interesting. The behavioral health providers, there was more likely a narrow network there, but this was 16% to 11%. So for both behavioral health and general medical, the marketplace product was more likely to have a narrowing of the network. But there were many more of the plans had narrowing in the general medical than in the behavioral health.
So let me see if I get this straight.
Yeah.
If I am in a marketplace plan, when I'm looking for like a general physician, it's much more likely that I'm going to be in a narrow network than a non-narrow network.
Compared
to if I were getting it from like my employer.
Right. And that same greater likelihood will apply in behavioral health care, but there are many fewer only 16% of the marketplace plans had restrictions or narrowing in behavioral health.
Right. And that number about the general practitioners is important, considering that a lot of people are getting their behavioral health care through their internists.
Possibly. We don't really know, but we don't know how this might affect things, but it's very striking that there's a greater narrowing, a higher density of narrowing in the marketplace product than the non-marketplace product for general medical providers. And in terms of the tiered networks, in this case, there was no difference between the marketplace products and the non-marketplace products for general medical providers, and a modest increase likelihood of the tiered network in behavioral health providers compared with the non-marketplace products. But again, there was only 14% of the marketplace products had a tiered behavioral health care network compared to 8%. So still, the likelihood of having a tiered network was low overall.
Right. And so just getting back to our original question about how do marketplace and non-marketplace plans differ, it really seems like the biggest way is through how they're organizing their networks.
Exactly.
And that has a lot of implications for how people receive services.
Both in the
yes.
behavioral health arena and in the general medical arena.
Right. And then the other interesting point is that in marketplaces that were run by states, those were more likely to use narrow networks than those that were run federally, which has a lot of implications. I mean, in the healthcare debate, we've been hearing a lot about kind of returning more power to the states. So it's a question about whether that will be something that happens in the future as well.
Yeah, so this, I think, was a very, actually beautifully written, very clear synthesis of what is a complicated array of conditions in the marketplace. And I recommend, I'm not a policy person, I'm not an expert on insurance, but I am a very interested and engaged psychiatric service provider, and I think this paper lays out some of what we've seen and then also lays out a lot of questions and worries about what may be coming.
Yeah, and if you've been following along the healthcare debate, a lot of these terms are going to be familiar to you, and I think that the paper can really kind of drive home how some of these issues are affecting behavioral health populations.
Yeah. That's it for this episode. I hope that you enjoyed it. We think a lot about which papers to highlight, and sometimes we choose papers that are challenging to describe. We hope that we've been able to make them clear and understandable to you all.
That's what we're shooting for.
Yeah. But we invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. We also welcome your feedback on everything from choice of articles to how thoroughly we cover them, and also whether our jokes, such as they are slightly funny.
No, they're definitely funny.
Again, we're amusing ourselves. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you so much for listening. We'll talk to you next time.